Welcome back to the Rebel Core Content Podcast. Core content for anyone, anywhere, and just in time. This is Swami, and I am back with our toxicology guru, Dr. Sanjay Mohan. Sanjay, we've had a couple of really good toxicology topics, and you've got another one for us.
Thanks for having me again, Swami. I can't believe the summer's over. It's back to school time.
Absolutely. Back to school. We've got some now not so fresh interns, but 3-month-old interns. We've got senior residents that are kind of new. And this is going to be a core EM tox kind of a topic. We call lots of tox consults in the emergency department. And Sanjay, one of the things that you guys always ask me, regardless of what the ingestion is he asked me for an ECG, almost to the point that I feel like you guys are cardiologists. I can't even have a conversation with you without having an ECG in hand. So why? What is the ECG to you? Why is it so important?
As with everything in medicine, you need to take into context the patient sitting in front of you. So for us, when someone comes in with an overdose specifically, I want to know what the QRS is, what the QTC is, and beyond that, are there any brady or tachy dysrhythmias?
Very specific things that we are looking for. And one of those is that QRS duration, if it's prolonged. And when it is prolonged, this is kind of one of those, if you see this and you're thinking tox, this is the answer that you should be reaching for. And so if the QRS complex is wider than it's supposed to be, we think about sodium channel blockade. That can even be outside of the toxicology setting, but it is one of the things that really occurs to us. And I think that this gives the non-toxicologist amongst us a little bit of palpitations because we're trying to recall our physiology, the different phases, and we're not going to get into all of that. People can find that elsewhere. But let's talk about that prolonging of the QRS, the sodium channel blockade. And when we think of that, what are the drugs that are kind of the classic ones that we should be thinking about?
By far and away, the most common, especially in today's world, is probably diphenhydramine or Benadryl, especially given that it's over the counter. Beyond Benadryl, I would consider tricyclic antidepressants, lamotrigine, bupropion, or loperamide.
The diphenhydramine thing I think is really important. This has probably been a switch over the last couple of decades. We don't see as much of the tricyclic antidepressants, although we know they're making a big comeback in terms of treatment for pain management kind of things, for patients with chronic pain, with phantom pain. Tricyclics are there. They tend to be aimed at a group that's a little bit lower risk than where we were giving TCAs before, which is probably why we don't see those overdoses as much. But we do still see them, and we definitely see diphenhydramine overdoses because, like you said, it's over the counter, it's easy to get, it's in a lot of sleeping medications, it's combo with other things. So I know we kind of alluded to this already, but let's get really clear on the ECG changes that we're going to see with a sodium channel blocking drug.
Totally. And the salient point with this entire topic is that sodium channel blockade will lead to QRS widening. If nothing else, that's the takeaway. The right bundle is more susceptible to sodium channel blockade than the left bundle. And as a result, all the rightward manifestations will appear in your ECG. So what does that mean specifically? Right axis deviation, terminal R wave in AVR, and a widened QRS complex.
And when we're talking about that widened QRS complex, this is a little bit different than what we think about with cardiology and our traditional ECGs, because when I think wide QRS ECG, I'm thinking about 120 milliseconds at 3 small boxes. That's kind of our traditional cutoff, but you guys are looking at a different cutoff. You're looking at 100 milliseconds. So what do you know that the cardiologists don't know?
In the cardiology world, to have a complete or a left bundle, you need to have at least 120 milliseconds. In the context of poisoning, however, I want you to think 100 milliseconds. And this is based off a landmark tox paper back in 1985 by Bonner and Lovejoy. And what they did is they looked at the relationship between QRS restoration and negative clinical events, specifically seizures and ventricular dysrhythmias. And remember, these were patients that were confirmed poisoned with tricyclic antidepressants. The takeaway, if the QRS was greater than 100 milliseconds, there was a 33% chance of having seizures. If greater than 160 milliseconds, there was a 50% chance of ventricular dysrhythmias. So really, in the context of poisoning, if you see a newly widened QRS greater than 100 milliseconds, you have to at least entertain the differential of sodium channel blockade.
And again, we're going to be focused on those specific medications, the diphenhydramine, the loperamide, lamotrigine, obviously the tricyclic antidepressants. Cocaine is in there as well. So you see this sometimes with the cocaine intoxication where the QRS will be a little bit widened. And again, we're going to be worried about seizures. And when you have seizures, the patient becomes more acidemic. When the patient becomes more acidemic, they become a little bit more likely to get ventricular dysrhythmias. These things kind of cycle on each other. So 100 milliseconds is the cutoff that we are looking for here to kind of trigger in our brain. We are very concerned about this patient. Most of the initial management on critically ill patients, and even the critically ill in the toxicology world, focus on ABCs. And we're going to do the same. We're going to address those ABCs. But when we're dealing with a sodium channel blocker, what else do we have to know in terms of management?
In an era where emergency medicine is trending towards more protocolized care, you need to be a doctor first and foremost. What's one of the first tenets of ACLS care? In the context of a new wide complex tachycardia, that is ventricular tachycardia until proven otherwise. So often, if a patient presents with a severe amount of sodium channel blockade and they look unstable, and the EKG looks particularly wide, your gut may tell you this is ventricular tachycardia, but you got to go back to the patient. In the context of poisoning, that's not ventricular tachycardia. Specifically, that is a wide complex tachycardia that is secondary to sodium channel blockade. So those patients, they don't need electricity. They need sodium bicarbonate.
And when in doubt, you can always do both. So if you have a story for a poisoning, but you're not quite sure, you can set up for cardioversion and give that bicarbonate at the same time. One of the things that we kind of fall by the wayside in terms of our knowledge is the amount of bicarbonate. You alluded to it, but let's be really specific. This isn't just give an amp of bicarb. It's a specific amount that we should be targeting.
The bolus dose is 1 to 2 milliequivalents per kilogram bolus. And if there is response, and by response I mean the QRS narrows or the patient's hemodynamics get better, you want to start an infusion. An infusion being 150 milliequivalents in a liter of D5W, generally at maintenance.
How much bicarb do I give before I say, I'm not getting any effect, I must have the wrong diagnosis? If I give 1 to 2 milliequivalents and I don't see any narrowing, should I give up at that point, or a repeat bolus is indicated?
So this requires a little bit of nuance, and you need to be at the bedside to really find the answer. If you have a good story, you push 2 milliequivalents per kilogram, and there's maybe a response, I don't think it's wrong to give another go at it. I could tell you anecdotally, some patients require a ton before you get them stable. I had one case that I actually had to provide 400 milliequivalents before starting an infusion before getting hemodynamic stability.
I think this is really similar to what we see with hyperkalemia, where we're taught you give calcium, but no one really tells you how much calcium you have to give before you should see an effect. Typically, you give a couple of grams and you get the effect, but I've given 9, 10, 12 grams of calcium before I see the narrowing. I had the right diagnosis. The patient just didn't want to respond the way they were supposed to. And this is another one of those places. So if you have a good story for diphenhydramine or for a TCA or any of these other sodium channel blockade agents, keep giving that bicarbonate until you get a response. Don't give up after a single bolus. I think that is really important. Now, one of the things that you said is that it's a new prolongation of that QRS complex. We have lots of patients walking around who already have left or right bundle branch blocks. So if the patient already has a right bundle branch block and we're worried about this poisoning, what's the cutoff for the QRS then?
Once again, with a high pretest probability of poisoning, and if you think they look sick and are hemodynamically unstable, what you can do is always trial management, specifically sodium bicarbonate. So get them on the rhythm strip, trial 1 to 2 milliequivalents per kilogram of bicarbonate, and see if their QRS narrows. Or moreover, and what's probably more important, see if they become more hemodynamically stable.
Clearly, we might be using large doses of bicarbonate anytime we give a medication, especially when we give a medication outside of our normal window. We have to be really keyed into the possible side effects. So what should I be looking for if I'm giving push after push after push of bicarbonate to just kind of remind myself of the possible toxicities?
This is a point that I really try to get my fellows to understand. If the patient responded to bicarbonate and you're starting an infusion, that's stage 1. But remember, at a certain point, you're going to induce alkalemia, and alkalemia will shift potassium intracellularly. So you may have saved the patient from sodium channel blockade, but you may kill them from hypokalemia. So the second you start an infusion, please, please, please replete potassium as well.
Great tips, a great review of sodium channel poisoning, sodium channel blockade. Let's hit some take-home points before we wrap up for the week.
In the context of poisoning, a wide QRS is anything greater than 100 milliseconds. A newly wide QRS, especially with hemodynamic instability, should prompt consideration of sodium channel blockade and not ventricular tachycardia. Treatment is guided by administration of sodium bicarbonate. Recall that the resultant alkalemia driven by sodium bicarbonate will shift potassium intracellularly. As a result, if an infusion is started, potassium should be simultaneously repleted to avoid life-threatening hypokalemia.
Excellent. That really brings everyone up to speed. I think, Sanjay, that everyone at least will have the beginning parts of management for these patients keyed into looking for those findings on the ECG, knowing why the toxicologist is asking for the ECG, what specifically they're looking for. This is all a great set of tools for us to have in this particular group. And that's going to be all for the Rebel Core Content podcast this week. We'll be back in 2 weeks on our cast. Until then, don't forget to pop on over to the site, check out all the great posts from our faculty. And until next time, stay safe.